Yes. Good morning and good evening, all my friend in ICC. Today is our 122 ICC webinar. I will introduce our invited speaker, Professor Jingtao Li. Jingtao, we already know each other in several the international congress, like the Seattle ICFS, the Kyoto Cleft, and we met each other and we have something in common. So we learn from each other as well. So this time is our special guest to address this special topic. And Dr. Jingtao Li is an associate professor and master supervisors at West China Hospital of the Stomatology Sichuan University, and where he also served as a deputy director of the Cleft Lip and Palate Surgery Department. He holds DDS and a PhD in stomatology and complete postdoctoral training in plastic surgery at Stanford University, as well as a visiting scholarship at the University of California, Los Angeles, UCLA. Dr. Li specialized in the management of cleft-related dental facial deformities and the rare congenital craniofacial anomalies. Dr. Li holds several academic positions, including standing member of the Cleft Lip and Palate Committee of the Chinese Stomatological Association and a member of the Maxillofacial Surgery Committee of the Sichuan Stomatological Association, and editorial board member of Plastic and Aesthetic Research and the Journal of Oral and Maxillofacial Surgery Chinese. And he is also a member of the Sichuan Rare Disease Quality Control Committee. Professor Li has authored over 60 more publications as the first and the corresponding authors and contributed to 5 internationally renowned books, including Comprehensive Cleft Care and Elegant Plastic Surgery. Today, he will share his experience in the topic entitled as the maxillary distraction osteogenesis for cleft patients. By the way, we invite 3 very good friends, and we know each other as well for a long time since we established the ICC webinar. The first one is Dr. Dex. Dr. Dex has become our fellow in Chang, and now he is very well known not only in Philippines as well in all Asia, and he focused the cleft care in Davao, and we met him several times, and we have some collaborative mission activity together in between Davao and the Chang. So welcome, Dex. And the second one is the Professor EK. And EK, Professor EK also, we met with each other several times in the International Congress as well. And the EK has a lot of experience as well in so-called craniofacial typical cases. So we are very welcome for his coming as our panelist today. The final one is the Dr. Jia Narisapam. Dr. Jia, this year he has a very important task to hold the FACE AO in Bangkok. So by the way, I would like to introduce and welcome all of you, can show you how enthusiasm to attend this very good meeting in Bangkok, and the first time be held in Asia. So welcome, Dr. Jia. So can wait to learn from Professor Jingtao. It's your short time. Let's welcome, please.
Thank you. Thanks so much for the introduction. It's the first time hearing the full-length introduction of myself in English. Sorry, I'm not very familiar with the Zoom software. Okay.
Yeah, it's good now.
It's good now? Okay,
yes.
Great. Okay, it's my great honor to be the first presenter for the year of horse in the lunar calendar. So Happy New Year. So Dr. Zhou just invited me in Kyoto, right? Where we also met Dr. Law and Dr. Fiaz. And I just found this week that Cai Ming from Shanghai just presented a very similar topic about a month ago for this ICC webinar. And his topic is distraction osteogenesis Shanghai experience. So my slides are about the Chengdu experience. We have a lot of contents that is overlapped because we work very closely. And I just started doing this orthognathic work about 5 years ago. And Dr. Tsai just gave me a lot of instruction, as well as Dr. Chen Yurui from Chang and many other surgeons. So this is where Sichuan province is. So it's in the southern western China, and my city is famous for panda and
Professor Lee,
delicious
I
food.
don't think the slides are switching. You're still stuck on your first slide, your introduction, the
How about
title.
now? Is it
Uh,
going?
no, not yet.
Um, it's moving on my screen.
Could you try it
How about I
again?
just
Yeah.
okay. So how about now? Is it on the second slides?
Good.
Yep. Now it's
One,
working perfectly.
it's working, right?
Yep.
Okay, great. So this is where my city is, southern western part of China, and it's famous for panda and delicious food. So we welcome everyone to visit. So I just start the topic today. So it's my very limited experience on performing this internal distraction osteogenesis for patients with cleft lip and palate. I'm sorry, I think the slides are switching by itself.
I think you can cancel the after 0.822 second, and then it won't switch by itself on the right, on the
This
bottom,
one
the one on the bottom.
on the
Uh,
this one,
yeah, the second one.
this
Yes.
one. Okay, great. Thank you very much. Sorry for the trouble. Okay, so in the modern cleft lip management, the primary care can already achieve very satisfactory outcome for the nasal labial morphology. But when the secondary skeletal deformity jumps in, it just sometimes it can make everything just got ruined. So according to this data, that this orthodontic treatment combined with orthodontic and distraction osteogenesis took over 70% of the overall medical burden of our cleft care. So the ratio of patients who
Excuse me,
demonstrate
Jingtao is
yes,
still not in the full screen, so it still
sorry,
remain on original slide. Mhm.
is it moving now?
No. Yeah. Mhm.
Okay.
Yeah.
How about now? Is it switching? Still got stuck.
Yeah, it's still stuck. Maybe what if we just don't go into full screen mode? Maybe that would
Okay.
be better. Yeah,
Okay, I'll try that.
thank you.
Mhm. How about now?
Better. Yes.
Okay. I think it's a problem with the internet because I'm using a VPN to get connected to use this Zoom software. Okay.
Okay. Yes.
So the ratio of the patients who demonstrate dental facial anomaly that requires surgical intervention ranged between 25% to 75% among the cleft centers in the world. And in my center, I just did a review on over 1,000 patients above the age of 16 using these three simple radiograph measurements to identify those who need osteogenetic surgeries. And about over 30% of the patients in our center demonstrate this surgical needed osteogenetic, this skeletal deformity. And then we further evaluate the severity of the maxillar hypoplasia among these patients. So I just did another measurements. It's the distance between the upper incisor to the vertical gall line. So these simple measurements just gives us like indication, like how the ideal position of the maxillary advancement. And we found that about 40% of the patients requires maxillary advancement less than 6 millimeter, and 45% of them requires advancement like 6 to 10 millimeter, and about 50% requires advancement larger than 10 millimeter. And these are theoretical patients. This graph just includes all the patients who received or did not receive osteogenesis surgery. For the patients are actually treated with the surgery, like only 11% of them can be corrected with advancements less than 6 millimeter. So another issue related to the cleft maxillary hypoplasia is the asymmetry of the maxilla. So the first step of the osteogenesis surgery is to position the maxilla to symmetric position. So this step, without even moving the incisor edge forward, we can notice some advancement in the maxillary tubercle on the cleft side of the maxilla. So that means that more patients, even more than this 11.57% of patients might require maxillary advancement larger than 6 millimeter. And so I think the core issue to have to be addressed when I first start doing this OGS surgery to the cleft patients is to find a way to effectively move the maxilla forward in large range. So let's see the surgery options for typical cleft patients with maxillary retrusion. So for these patients, according to the measurements, we see that the angle SNA is smaller than standard. So the maxilla is hypoplasia, but the mandible is largely normal from the profile, and the width value is about 10.5 millimeter. So then we usually have two like options. So first is the conventional double jaw orthodontic surgery. So on the surgical table, the maximal advancement distance for the maxilla is about 5 to 7 millimeter, according to the literature. And to correct the crossbite, we have to simultaneously set back the mandible for about 6.5 millimeter. And at the same time, we might have to do this genioplasty to keep the position of the genium. So the other option is to do a single jaw distraction osteogenesis to advance the maxilla for like 12.5 millimeter. So this is one of my early case. At that time, I don't have appropriate distractor to do this maxillary distraction. So I choose the first conventional double jaw surgery option. So after the surgery, the crossbite is well corrected, but the patient was not very satisfied about the morphology because he think that nasolabial depression was not well corrected. And also, after the surgery, the patient had experienced temporary snoring. And compared with the single jaw surgery, this double jaw OGS caused more trauma and with higher cost. So as a quick comparison between the OGS and DO, actually the maxillary distraction osteogenesis has many advantages, like for the cleft patients, including the range of the advancement, stability, and the profile improvement. But it also has two significant drawbacks. First is life interference, especially when you choose these extraoral RED hardwares to do this distraction, right? A lot of patients just simply cannot tolerate wearing these hardwares for at least 6 months. And another drawback is the lower accuracy when compared with the osteogenetic surgery, because after the surgery, you still have to move the bone segment about 1 millimeter a day. So this process may not be as accurate as you place the maxilla to the position where you want it to be on the surgical table. So when I first doing this maxillary distraction osteogenesis, I tried to figure out a way to reduce these two drawbacks. So I think the most important thing for successful distraction osteogenesis is to choose the right hardware. So the RED, I think, is one of the most widely used device to do this work. It's reliable, effective, and it's kind of adjustable during this distraction process. But it has very significant disadvantages. It has interference, great interference to the physiological functions, and it causes scars on the head. And according to the literature, and severe complications, including the intracranial penetration fracture infection, has also been reported. So I personally, it's not my first choice. So some other distractor designs are also available in the literature, like these three mixed two-bone anchored intraoral distractor, but they are not very comfortable either, because major part of this kind of devices took the space of the oral cavity in the vestibule space. It interferes to the speech feeding and it's not very easy to maintain the hygiene of the oral cavity. And it has to be highly individualized manufactured. So it's not available, at least in mainland China. And another option is the bone-anchored intraoral distractor, which was available when I first started doing this in mainland China. But after using it on a few cases, I've just found it very inconvenient. The first is that it's still not very comfortable.
I think we might be experiencing some technical difficulties.
Sorry?
So, I think there was a little bit of lag, so your voice was paused, but now it's normal now.
Oh, okay.
Yes. Okay.
Yeah, I'm sorry. I have to use the VPN to log onto the Zoom software. I think maybe that's the
No, no
problem.
problem. It was really smooth previously, so no worries.
Okay.
Please proceed.
Okay.
Thank
Okay. So on this slide, we can see the protrusion of the distractor just on this against the vestibule. And another drawback of this kind of distractor is that it's impossible to keep the bilateral distractor in parallel position. So this will cause the collapse of the bony segments. Like for these patients, I did this AMDO, anterior maxillary distraction. So like the surgical planning is to move the bone segment in a more horizontal vector. But on the surgical table, I just cannot place the distractor as I planned to do. So we can see a significant downward movement of the bone segment. So my option just falls into this internal distractor where most of the parts is completely buried under the soft tissue. So there are three positions to put the distractors, like the nostril, the maxillary sinus, or the subzygomatic position. So since sometimes we need to deal with the bony defects at the alveolar cleft at the time of the OGS or the distraction osteogenesis surgery, so my selection is the subzygomatic internal distractor. And based on the design of the brands, since these distractors were still not available in mainland China, so I just made some modification and found a manufacturer to produce it for me. I believe in Dr. Taiming's slides, he also showed some case of this, the use of this kind of distractors. So it's not, I didn't got the design from zero. I did it from the modification of previous works. Like this is a work published in over 20 years ago by the Beijing University. They used some personally individualized distractor to do this maxillary distraction and reported very good outcome. So this is my first case using this internal distractor. So the mandible is largely normal. The maxillary is retruded. I did this virtual planning and want to move the maxilla forward about 11 millimeter. So I pre-bent the distractor and I try to place it in the same position on the surgical table. And after we finish the distraction, the rod can be removed. So there's nothing left in the oral cavity. The patient is very satisfied about the improvement in the profile, and it's as comfortable as conventional OGS after remove the rotation rod. But my orthodontist and me were not as satisfied as the patients, because even though the distractor can move 15 millimeters, we just used the full distance still. We didn't get the sufficient advancement movement. So we can see at the end of the orthodontic treatment, we can see that the orthodontist has been trying to compensate the crossbite. So that's the problem in the accuracy. So after reviewing the radiographs of this patient, we found that although I tried to pre-bend and on this printed model and try to place it in the same position on the surgical table, still I cannot guarantee that the distractor on both sides of the maxilla is in parallel position. As we can see that it's in a pretty big angle. So this error just increased from the planning to the pre-bending and to the implantation. So in the literature, it says when you do the pre-bending, you just use a set square whenever possible to do this work. And when I was doing this pre-bending, I think from my naked eye and the free hand, I have done whatever I could do, but still we see this inaccuracy. And also on this case, it's more obvious. It's maxilla distraction. So the distractor was not parallel to each other. And during the distraction process, we can see the angle between these two distractors just increased. And after we distracted for about 5 millimeter, the bone segment is not moving at all. So we keep rotating the distractor, but the bone is not moving. It's just they're fighting with each other. So to solve this problem, we just use this digital techniques to do this. So our solution, like for these patients who needs 10 millimeter advancement of the maxilla, we just did this virtual planning. We rotate the maxilla to align the midline of the maxilla, and then we decide the distraction vector depending on the final occlusion as provided by my orthodontist. And from there, we fabricate this occlusion-based surgical guide. So this guide is like a ordinary occlusal plate, just with two arms, with two tubes that indicates the vector of this distractor. So I use the same guide to do this pre-bending on the 3D printed model and do the implantation on the surgical table. So we can see that we keep the distractor in the same direction as the surgical guide, both at the pre-bending and at the in the intraoperatively. So by using this technique, we can see that we can ensure that the distractor vector on both sides of the maxilla is parallel to each other. And for these patients, we just we achieved a pretty accurate advancement. We can see that the occlusion at the end of the distraction is very close to the designed occlusion as provided by my orthodontist. And this is another more extreme case. Like this patient requires 50 millimeter maxillary advancement, and that's the maximal distance of my device. So if it's not very accurate, I just cannot move the maxilla sufficiently. So I also did the simultaneous alveolar bone graft for these patients. We just do single jaw surgery, the mandible after the clockwise rotation. It just looks pretty good. So this is a target occlusion, and this is what we got after the distraction osteogenesis. As we can see from the radiograph, the bilateral distractor completely overlapped with each other. And this is the immediately after the distraction, and this is 6 months after distraction. We can see that the angle of this distractor, the distraction vector just was very stable. And on the lower left image, this is immediately after distraction. We can see that the distance, the movement distance of the distraction plate is about 15 millimeter, and the distance between the cutting edge of the maxilla is also 15 millimeters. So 6 months later, we can see that the bone just grow into the just fills the distraction gap, and the distance was well maintained. And we compare the stability between this internal distraction osteogenesis and the conventional OGS, and the stability is significantly better for this distraction technique, which is consistent with this with the literature. So that means we solved the problem of the stability part. And we just compared the outcomes with 3 distraction protocols. The first is using the intraoral distractor, where it's impossible to put the distractor in parallel position. And then the second protocol is to use the internal distractor, but not using the virtual, without using the distraction guide. And the third is the internal distractor and the computer-assisted protocol. So we can see that the accuracy was significantly improved when I started using the technique with computer assistance, and the accuracy is about the level of the conventional OGS. So in that case, by solving these two problems, I think the internal maxillary distraction osteogenesis serves as a powerful tool to correct for correcting the cleft-related maxillary hypoplasia. By choosing the appropriate internal distractor and sorry. And using this computer technique assistance, we can achieve reliable, effective, relatively comfortable, accurate, and convenient maxillary advancement with large range movement. So this gives us adds a very powerful tool to our treatment techniques. So after achieving this accuracy, this kind of accuracy in this single jaw surgeries, my orthodontist also gained more confidence and allows me to do this bi-jaw surgery in one stage. Like for this patient who has a protrusion and deviation of the mandible as well as a maxillar hypoplasia. So in my conventionally, we have to do this in two stages because the maxillary distraction osteogenesis is not very accurate. So usually we first do this distraction osteogenesis, and at the second surgery, when we remove the distractors, we do this jaw setback. Like indicated here. But as we achieved pretty high accuracy for this internal distraction osteogenesis, we try to do this in one stage. So this is the designing of the patients. We try to move the maxilla about 9 millimeters forward, and we fabricate this very similar guide to help locate the distraction vector of the, and also we use this mandible guide to help us to set back the mandible on the surgical table. And also we fabricate this final guide, which will be used by not on the surgical table, but by the end of the distraction process to help us to check if we have moved the maxilla to the target position. So this is the patient after we finish the distraction, immediately after distraction, and it's pretty consistent with our surgical designing. And on this video, I'm not sure if, yeah, likely we can play it. So this is by the end of the distractor. We put in the final occlusal plate, and by some minor adjustment on one side or both sides of the distractor, we can provide some very accurate adjustment to help the patient to bite accurately into the final into this final occlusal plate. And my orthodontist is pretty happy about this position, and it's pretty consistent with the target she set before the surgery. And this is another patient from the infant, and who also did this two-jaw surgery. And we also did this mandible, like the contouring, also, everything in this one-stage surgery. And this is a patient after rhinoplasty. And also, since we can move the bone accurately, we started to consider this surgery first protocol. And according to many surgery first literature, some of them has listed patient with cleft as a contraindicator to this surgical first protocol. But I know that in Chang, like we do, many of the patients were operated like surgery with surgery first, and is like this paper is like 2 years ago or 1 year ago, like you reported very satisfactory outcome for cleft patients. So after discussing with my orthodontist, she allowed me to try to do this surgery first using this internal distraction osteogenesis. So the reason we choose to do this is from this case. Like this patient is from the Tibetan region of China, where it's very remote, and the patient simply cannot afford the orthodontic treatment. She has to travel like 2 to 3 days to our hospital. But my orthodontist just found, although she has very malaligned occlusion, but after we he positioned the tooth cast, he found that he can still find a position where there are 3-point contact between the upper and lower denture. So we just decided to do this. Actually, it's surgery only, like treatment to these patients. So she requires about 12 millimeters advancement. So using the same technique, we achieved a target occlusion as designed by my orthodontist. So this is the patients from infancy to after the surgery. Oh no, that's before the surgery. So this is our designing. Moved to 12 millimeter. So during the surgery, we use this cutting guide, and we use this distractor assisting guide. And we also use this final occlusal guide at the end of the distraction. So this is the intraoperative placement of the distractors. So this is the patient after the distraction and after rhinoplasty. This is the profile. And this is 6 months after distraction osteogenesis. We can see that the position of the mandible, the maxilla is pretty stable, is well maintained. So from the success of that patient, we found that maybe a well aligned tooth arch might not be the prerequisite to do this internal maxilla distraction osteogenesis. So my orthodontist just agreed to do this bi-jaw surgery and using this surgery first protocol. So to accurately position the bone, we just virtually simulated the tooth alignment, and then go back to this to the present dental form to decide where the bone should be placed on the surgical table. And this is the target occlusal. I'm sorry, I forgot to translate this into English. So this is the surgical target. This is the actual occlusion we achieved. And this is the patient in the progress of orthodontic, post-operative orthodontic treatment. This is another case receiving the same procedure, like the simulation of tooth alignment. We got this target occlusion, and we did this internal distraction osteogenesis and mandible setback in one stage without pre-surgical orthodontic treatment. So this is the target occlusion and the post-operative occlusion. This is another similar case. So far, I still haven't got like a sufficient case to with this final outcome, because I just started using this protocol like 2 years ago. So my orthodontist has not returned finished case to me. So I'm still preservative like on this experience, on this surgical first experience doing this bi-jaw surgery among patients with cleft. And also for some marginal cases, like if the surgical planning suggests to move the maxilla forward about 5 to 7 millimeters, how do you choose between the OGS and distraction osteogenesis? Because on the surgical table, I found the difficulty of moving the maxilla forward varies among patients. For some cleft patients, it's very easy to move the maxilla forward to like 7 millimeter, and some of them, it's difficult to move even like 2 to 3 millimeter. So I think maybe the resistance mainly from the palatal scarring, I guess, might be the reason causing such differences among patients. So I just measured this traction force that's required to position the maxilla forward. And I found that when the traction force is above 8 Newton, the relapse is significantly increased. So currently, I'm preparing 2 plannings for these marginal cases. So on the surgical table, I will measure the traction force and decide which protocol to use, distraction or conventional OGS. And also for this, cleft patients, the maxillary endodevelopment can be divided into retrusion or hypoplasia. If significant hypoplasia exists, like if we just align the tooth by extracting the crowded tooth, we will get very short denture and just sacrifice the occlusal function, right? So for this kind of patients, it's more appropriate to do this anterior maxillary distraction osteogenesis. So this is not the focus of my current slides, but I want to. The reason I put this case is that so by doing this anterior maxillary distraction, we got more bone volume. We got the space to align all the tooths. We keep all the tooths, and the occlusal outcome is better. The reason I mentioned this anterior maxillary distraction is that when I just use the tooth level distraction, sometimes I will see this counterclock rotation of the bone segment, where the patient's the occlusion, the crossbite got corrected, but the nasolabial depression is not well corrected. And when I also have used this RED to do this AMDO at the level of the bone. So I got this clockwise rotation where the profile looks good, but the crossbite is not corrected. So currently, sometimes I will use this 2-level distraction. So I will just use the internal distractor and this tooth-borne distractor. So in this case, I can just adjust the rotation, the movement of the anterior maxillary segment as I want. So by the end, I would like to share the complications I encountered during this internal distraction osteogenesis. I reviewed 114 cases that received this. So most of the most common complication I encountered is hardware exposure, because I placed the plate on the maxilla at a pretty low level where it's almost parallel to the root to the tip of the tooth root, and so that I try to prevent the counterclock the clockwise rotation of the maxilla segment during the distraction. So like in 24 patients, I noticed hardware exposure by the end of the like when they come back to remove the distractor. But I do not worry too much about this because I think it does not like sacrifice the stability or accuracy of this distraction process. And none of my patients complained after I explained to them that it won't cause something severely. And 18% of the 18 patients like reported VPI, vilopharyngeal insufficiency, after the surgery. Of course, after the large range maxillar forward movement, we can see that the gap at the nasal pharyngeal level just increased. In the literature, people have reported some risk factors for this VPI after OGS surgery, and patients with marginal vilopharyngeal closure is more susceptible to VPI recurrence. And infection occurred in 5 patients. So they just send me pictures saying that they experience swelling or just pain on one side or both sides of the maxilla. So, but so far, all of the patients were well managed with oral antibiotics. And 6 patients reported limited mouth opening. This complication occurs to my early cases because when I reviewed these cases, I found the distractor was very close to the ramus of the mandible. I think that's the reason although none of them were in direct contact with the mandible, but the soft tissue swelling might just increase the crowdness in this small anatomic region. So after I noticed this phenomenon, so I just modified the position of the distractor, and sometimes I will remove part of the bone on this zygoma, so to keep a safe distance between the distractor and the ramus. So after this modification, I have not received complaints about limited mouth opening anymore. And insufficient distraction. So like this patient has been demonstrated in my earlier slides, that this insufficient distraction is due to the unparalleled placement of the distractor. Like they're fighting with each other. But in this case, it's different. For this case, patients, like he has a very narrow bone breach, like at the cleft alveolar site. So during the surgery, I just accidentally like fractured this bony breach. Although the distractor were placed in the parallel position, but by the end of the distraction process, I keep rotating the distractor, but the bone is not moving anymore. So when I checked this CT scanning, I found that after the fracture of this alveolar bone graft region, the bony segments the bony segments start to collapse into this cleft space during this distraction process. During this distraction process. So after that, like for patients with insufficient bone grafts or just unrepaired cleft alveolar, I will have them to like wearing this occlusal plates immediately after surgery to maintain the stability, the relative stability between the two the bone segments during the distraction process. And I also like experienced 2 complete failures during this internal distraction osteogenesis. For this patient has highly severe maxillary hypoplasia, more than 2 centimeters. So at that time, I was pretty confident about with my internal distractors. So I just made the surgical planning as usual, completely neglecting the severe scarring on the palate. So this is before this is before on the before the distraction, and for the first distraction osteogenesis, the bone just simply did not move at all. I was suspecting that I might have not fractured the bone completely. So I go back to the surgical table and just fracture the bone again. Make sure that the bone is completely freed from the upper segments, and then I place the distractor again. And this time the bone moved. It moved like about 15 millimeters. And 1 month after that, the bone just completely moves back to its original position. So I guess that's because the stiffness of the scar tissue on the hard palate. So when when I check this patients after the bone segment goes back to its original position in the oral cavity, I found that the 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 plate of the distractor has actually got loosened already. I think that's because the strength of the titanium plate is not strong enough to to counteract with the stiffness of the hard palate scar. So that's why the bone just got complete relapse. So I have to go back to the RED, which provides more much stronger anchorage, and this time I just got success advancement. That's my failure, and this is another one, similar case, very severe retrusion and very heavy scarring, and yeah, failure. The bone just didn't move. I also switched to the RED to correct this case. So so now for the case with very severe maxillary hypoplasia, I would say that I would try to do this internal distractor first. But if I would just tell the patients before the surgery that if it doesn't work, we will just switch to RED as soon as possible. And so in summary, this is the current protocol I'm adapting to treat the patients above the age of 16. So I just separate them into the retrusion group, hypoplasia group, and retrusion plus hypoplasia group. And for the maxillary retrusion group, I do this Lefort 1 total maxilla forward movement. If the traction force on the surgical table is less than 8 Newton, I just do conventional OGS. Otherwise, I would do this maxillary distraction osteogenesis. And that's all the stuff I want to share today. And a short advertisement, just in June 21st, we are hosting international forum in Chengdu. And also, I think Dr. Fias is coming, right? So our government is going to cover the hotel. So everybody who's interested, please contact me. Thanks very much for your attention.
Thank you so much, Professor Lee, for this very comprehensive talk. And also, I learned a lot today on your mandibular distraction osteogenesis methods. So thank you very much. Now, I'd like to invite our panelists for some discussion. So the first panelist that I'd like to invite is Dr. Dax.
Yeah. Hi. Thank you. Dr. Lee, thank you so much for that talk. Excellent presentation and fantastic results. Actually, it's very refreshing that you actually presented your complications because actually it's very nice because most of the questions that I have actually revolves around them, but most of it actually you already answered, you already tackled on how you fix them. But maybe I'll just narrow it down to two questions. The first thing is, you did mention about the palatal scarring because that's the first thing that came to mind because there are patients where we have to do some redo palatoplasties, right? So could you kindly walk us through your decision-making process as to, okay, this patient, I can probably still do my maxillary distraction osteogenesis, and this patient might not be a good candidate. How do you assess those patients? What do you look for? That's the first question. The second is, you did tackle on there's about 18% that have VPIs. And there were studies before in Chang, if I'm not mistaken, it was around 10 millimeters where the VPI can become significant. So have you identified a certain parameter where beyond this measurement of distraction, there's a higher chance of having VPI? And if so, would it benefit if, for example, we do it in a stage procedure where we stop short of that and then we call in our SLPs and then have them make the musculature adapt and then we continue the distraction afterwards?
Yeah, that's two very good questions. So first, like my decision tree, when I see to evaluate the palatal scarring, right? So most of my patients receive the primary cleft palate repair like elsewhere when they come to me to do this osteogenesis surgery. So I cannot decide the heaviness of the scarring on there. So like it's very difficult to predict the stiffness of the palatal scarring, like with only this visual examination, right? I know that in the literature there are some like classification or evaluation too for the heaviness of the scarring, but it's not very like sophisticated. So like currently I'm still like basing my surgical decision on the range of the maxillary movement. Like if it's less than 5 mm, I would definitely first try OGS, right? At least I would prepare the planning for OGS on the surgical table. Then I would just using this like this device to test how heavy is the scarring, like the resistance, how big a resistance I am encountering to move the maxilla forward. I do have seen patients where the scarring, like from the intraoral examination, the scarring is not very heavy, but on the surgical table, after like cutting the bone completely, I just can barely move it forwards. I just rotate it like driving a car, but still it's not moving forward. It can rotate to the left or right, but it just cannot move forward. Yeah. So I think the surgical decision for this kind of patients is on the surgical table. Is on the surgical table, and for like for the two case of the failure, right? The two failed case I introduced by the end of the slides. So learning from these two failures, I would just talk with the patients who have very severe scarring and requires significant movements, forward movements. I would just say, okay, I would try internal distraction osteogenesis first because it's more comfortable. It has less interference to your life. But if it does not move, like 1 week after the surgery, I start doing the distraction. If the bone is not moving as I wanted, let's just go back to the surgical room as soon as possible so that we do not need to do the osteotomy twice. Yeah, so that's my consideration on this issue. And the second question is about the VPI after OGS, after maxillary advancement. Yes, we see like 18% of them report this. Yes, like the preoperative velopharyngeal closure status, as well as the advancement range, both have been reported in the literature as a risk factor to this VPI after OGS. But I also did some logistic regression analysis on my case, but I know the Chang report that if the advancement is larger than 10 mm, it has a higher occurrence of the VPI, but I just didn't find the significant correlation between advancement range and this VPI occurrence. So I'm not saying that it does not exist, because theoretically, yes, you remove the maxilla too much, the soft palate just goes along with the maxilla, the space goes on, just increase significantly, you just got nasal emission. But maybe it's because the preoperative status in my cohort is very more significantly, because I know that in Chang'an, the patient is more more consistent, right? It's more consistent. Most of the patient receive the entire treatment in their center. Yeah. So in my case, I just found the preoperative marginal velopharyngeal closure as a significant risk factor to this VPI recurrence. Thank you.
Yeah, got it. Thank you.
Thank you, Dax. Next, I'd like to invite Dr. Narissa Porn Chaprakit.
Okay, hello. Thank you
Hi.
very much for such an excellent and truly inspiring lecture. The clinical case you presented were extremely compelling, and I was particularly impressed by your innovative strategy for imaging severe maxillary hypoplasia in Cleft patients. The way you integrated digital patterning with precise vector control was especially impressive and thought-provoking. May I ask which software you used to design the distraction positioning guide and which 3D printing system and material you selected for fabrication? Given the range of the guide, I imagine specific technical considerations what are necessary to ensure both accuracy and structural rigidity.
Okay, just to make sure I
Yeah.
got the question right, since my English listening is not very good, as you can tell from my presentation. So just to make sure I got the question right, you want to know like what device I use for the, which software I use for the virtual planning and what material or the printing device I use for fabricating the guide? Am I right?
Yeah, for the software 3D printing system and the software that you design the detection positioning guide and the material you selected for the fabrication.
Okay, so that's something I don't know because I have I have a technician group doing this. They are highly sophisticated. Yeah. But I know the software. They use Mimics. I think that's the software used by most of the centers. And for the material of the 3D printing, we use resin, the resin one. It's cheaper. But recently they also switching to a 3D printed metal. I think it's titanium. Yeah, it's titanium or just iron. So it's metal. It's thinner. But I actually prefer this resin surgical guide because it's easier to just modify it on the surgical table. If some part of this guide is interfering with the with my surgery maneuver, I can just trim it very easily. But if it's iron, it's more difficult just to trim it.
Thank you.
Thank you.
Thank you. Thank you, Dr. Norisaporn. And last but not least, I'd like to invite Dr. EK Tamada.
Hi, Professor Lee. Thank you very much for
Hi.
your valuable lecture. I have performed destruction of osteogenesis with Lupo 3, but rarely with Lupo 1, so this lecture was very informative. And I'd like to ask you a couple of questions, if that's okay? Please
Yeah.
answer one by one.
Sure.
First, regarding the difference between bilateral and unilateral protocols, I believe that bilateral cases have stronger resistance due to the scar tissue than unilateral cases. How do you reflect this in your decision-making process? What you just decide by the resistance force on the surgical table?
Yes, definitely the bilateral cases are more complicated as always, right? Especially the premaxillary part. Like if the cleft alveolar is not well repaired, it's just it just leaves all the troubles to this OGS treatment. So usually theoretically, these bilateral cases, especially complete ones, right? The scarring is usually heavier, right? And theoretically, heavier scarring leads to higher resistance. But yeah, I didn't differentiate the unilateral or bilateral cases to my protocol. I just measured this traction force for both unilateral and bilateral cases. It's just in case of patients with insufficient bone repair at the alveolar cleft, we will like do this, use this we will fabricate a occlusal plate to maintain the relative position between the bony segments to make sure that during the distraction process, the bony segment will not collapse into this cleft space. So that's the only, that's the major difference or the major consideration for treating this bilateral cases and for unilateral cases without sufficient bone repair. Yeah.
Thanks. My second question is regarding your final adjustment. Your system is great because it allows for final adjustment at the end of the distraction process. And can you pull back on the distractor if you think it has been distracted too far?
Yes.
Oh, that's good.
Yes. So like I use this final occlusal plates by the end of the distraction process to check if the maxilla has reached my target position. So like the arrow always exists, right? Arrow always exists. So like usually I will put on this occlusal plate and to see whether the midline of the upper tooth it aligns with this occlusal plate. If it's like too much to the left, I would just rotate more on the left and maybe like rotate back on the right side to like rotate the maxilla a little bit.
Oh, thank you very much. Because I always using the distractor that cannot move backwards. So yeah.
Oh yeah, because I think it has the distractors without that cannot be rotated back has both advantage and disadvantage. The advantage is that it prevents relapse. Right? It's like a lock, like of the position of your final like movements. It's like a lock. Like for some of my cases, and also it has been like Professor Timing, who just presented like last month, he also shared his experience that after the distraction process, we removed the rotation rod, and then we compare the radiograph immediately after distraction and 6 months after distraction, we can see on the image that the rotation plate just goes back. So the relapse force may be caused by the soft tissue, the scarring contraction, just pulls the distraction plate backwards, causing the relapse. So yeah.
Thank you. My last question is I'd like to just reconfirm your approach. At this moment, do you usually use surgery first approach for every case?
No.
No.
I have to confess no, because you know, I have a deal with my orthodontist. So as a surgeon, I always want to do the surgical first protocol, right? We surgeons all want to do that, right? The patient comes in, we just move him or her to the surgical table as soon as possible. But the orthodontist always say, hey, hold on there, just wait. We have to like do this 1 or even 2 years pre-surgical orthodontics. So I have to say I made a deal with my orthodontist, who is also my wife, actually. So she agreed. She agreed to try 10 cases for me, but we have to wait until the final result to see if we continue using this surgical first protocol for the patients. It's just I think this is due to our limited experience. We should learn more from Chang group because they do a lot of surgical first experience. I think the question should leave to Dr. Luo and Dr. Zhou.
Okay.
Yeah, thank you.
Thank you very much for your good lecture. Thank you.
Thanks very much for your comment.
Thank you, EK. And now I think we should ask Professor Low and even Professor Fayaz to comment. And maybe we should ask Professor Fayaz to comment first.
Hi, Dr. Fayaz. So you haven't turned on your mic.
Professor Fayaz, you're on mute.
Yeah. Thank you very much, Jingtao, and very
Hi.
good lecture and very enriching. And we learned a lot. And I'm trying to encourage my colleague to learn orthodontic surgery and these type of procedures so that we can help many patients, because we have many patients where the maxillary growth has been retruded. And I'm not sure in any of the government hospital this such facility is available. However, we are trying to start at Cleft Hospital soon, when one of my colleagues goes to Chang and learn these techniques. So thank you very much, Jingtao, for your enriching lecture.
Thank you. We'll talk more when you visit Chengdu in June.
Yeah.
Okay, thank you, Professor Fayaz. Professor Low?
Yeah, Dr. Lee, yeah, thank you very much for your talk. And actually, I enjoyed your presentation. A couple of questions I would like to listen to your response. You mentioned that for some patient that could be borderline, so you prepare two plans and test the resistance during the operation.
Yeah.
Is that right? Okay.
Yes.
So for what percentage of patient that you can estimate before the surgery that could be either conventional OGS or destruction?
So this is decided by our pre-surgical planning. Like I define the marginal case as rows with planned maxillary advancement between 5 to 7 millimeter, because I think that's the maximal range we can achieve in the conventional OGS. If it's below the 5 millimeters, I can almost for almost all the cases I can successfully advance the maxilla on the surgical table. But yeah, so that's why I define this case as marginal.
Okay, so it's in your practice when you do orthodontic surgery OGS, you do one jaw, two jaw, or what percentage between these two choice?
You mean between the distraction choice and the OGS
No.
choice?
I mean, in your practice, when you do the OGS, not distraction, you do one jaw or two jaw, or
so OGS mostly two jaw.
Mostly two jaw. It's good.
Yes.
So when you finish the destruction, how many cases that you have to do a secondary bone management, or you do the bone management at the end of destruction or during the same procedure in the destruction?
You mean how many patients I have to do OGS after distraction osteogenesis?
When a case that you plan to do reform and destruction, you do after you finish the destruction, what percentage of cases that you need to do a secondary bone surgery, such as BSSO, the mandibular surgery? Yeah.
So if the mandible is normal, I mean, if there is no protrusion or deviation of the mandible, I would just design the single jaw distraction, and also it's very stable. So a very low percentage, I have to say. I don't have exact data here, but for this case, if the mandible is normal, a very low percentage of patients needs to do further bone surgery, because I think the distraction outcome is pretty stable. I can move the maxilla to the position I want. So for this group of patients, the secondary OGS is pretty low. I think it's below 5%. Yeah, I'm confident about that. Yeah.
Okay.
Yeah.
So very nice.
But for the patients who received both maxillar distraction osteogenesis and mandible setback at one stage, I do have patients coming back to redo this mandible surgery. Most of them are complaining for most of the cases who require secondary OGS is complaining about the deviation of the mandible. That group of patients, the secondary surgery rate is about 10%. I have to confess.
So you also do, for some cases, you also do maxillary for one for destruction, and at the same time, you do mandible surgery to adjust.
I would do them together.
The same time. The same time.
Yeah, the same time. Yeah.
Before destruction, right?
Yes.
Okay. Good.
Thank you.
Because I'm asking because there's a lot of patients in my practice that actually I found that I have to do two jaws. So we actually we're lucky that our case the maxillary hypoplasia is not as severe as seen in your cases. Now the other question is that regarding the alveolar cleft, some patients either unilateral or bilateral cleft, the patient may not have alveolar bone graft before they come to see you. How to manage this group of patients? You do bone graft first, or you do bone graft after the destruction? I heard that you say that in one case you do is simultaneous alveolar bone graft. Yeah.
Yes.
How do you manage this group of patients?
So I prefer to do bone graft first, especially for those who will do this long-term pre-surgical orthodontic treatments. So they have time to do this surgery. So yeah, it's ideal for me to have a stable and continuous bone maxillar segment before I do this leaf forward one. But I do have patients who just refuse to do this alveolar bone graft. Some of them might have experienced might have taken a failed alveolar bone graft already, so they just refuse to take it. So for this kind of patients, after I do this leaf forward one osteotomy, it becomes two separate segments. So I have to put on this occlusal plates on the surgical table and keep these occlusal plates in place for at least 2 months to make sure that they are stable during this extraction.
Okay, good. Very nice result, I have to say. And please say hello to my friend in Xi'an, Sichuan.
Thanks very much. Thanks very much. Thanks for sharing your valuable experience.
Chengdu, I forget that. Chengdu, Sichuan, yeah. Say hello, including Professor Sibin.
Yeah. 谢谢. Thank you.
Thank you, Professor Lo. Now I think we'll go to our Q&A session. We have a lot of questions from our audience, so we'll go through them one by one. So the first one is from Dr. Bipolish, and the question is, are there any instance that the OGS leads to palatal fistula? And if yes, then how do you manage it? And how long do you have to keep the occlusal splints post-op?
I'm sorry, I didn't get the first question about the fistula. So you mean fistula?
Are there any incidents where OGS leads to palatal fistula?
No, I haven't seen any fistula formation secondary to the OGS, because I just do this leaf forward one osteotomy like from this buccal side incision, right? So I have seen a report from Peking University, also mainland China, that they do this osteotomy from the palatal side of the maxilla, and they report like higher occurrence of fistula after that. So for this leaf forward one osteotomy, a conventional leaf forward one osteotomy, I have not seen any fistula after the surgery.
Okay, and the second part of the question, how long do you have to keep the occlusal splints for?
So if it's single jaw surgery, so maxillar distraction osteogenesis only, I do not keep the final occlusal plates in place because I think it's pretty stable already in case that the alveolar cleft has been well repaired, right? Because I think the distractor is strong enough to keep the bone in place. But if it's the patients with insufficient bone repair, that means that after the distraction, the bony segment is there are 2 or 3 separate bony segments. I will keep the occlusal in place for 2 months because at the first month is during the distraction process. I have to make sure that the bony segment does not collapse, and the second month is to have the soft tissue stabilize, achieve primary stability. Yeah, 2 months. That's the protocol I'm using.
Okay, and our next question is from Dr. Zhao, and the question is, where is the target place to insert the zygomatic distractor?
Okay. So the target place of the distractor, first, it cannot interfere with the rammers, right? To prevent the mouth opening limitation. So the second is about it's just I try to place it as high as possible, But well, it has to be like very close to the lateral wall of the maxillary tuberosity, and it has to be higher than the adhesive gingiva, and yeah, around that place. And I think just for each of the patient, it's just not very adjustable for the position where you put it. I think the things we can adjust is direction, the distraction vector of the distractor. Yeah, that's the vector is decided by the final occlusal position as designed by the orthodontists. So so the vector is actually a line connecting the final position of the maxilla to its original to the beginning of the distraction. So you decide the vector, and then you just put it like immediately medial to the lateral wall of the maxillary tuberosity. If it's too close to the rammers, you just remove part of the bone and there, and just to move it medially a little bit. Yeah.
Okay, and our next 2 questions are a little bit similar, so I'll ask the second question first from Dr. So. The question is, have you any experience using distraction osteogenesis in cleft cases where there is no bony union across the alveolar cleft? Now, I know you mentioned about doing a simultaneous grafting, right? So
yeah.
yeah, so the question is, could you share any protocol that you typically follow for this type of condition?
Okay. Actually, the simultaneous grafting is not for the purpose of immediate stabilization after this leaf-1 osteotomy, right? So the question actually has been raised by a previous question, actually. So how to manage patients with no alveolar bone graft, right? So for this kind of patients, the major obstacle for a successful distraction osteogenesis is that after you finish this leaf-1 osteotomy, it turns into 2 separate bony segments, right? If there is no bone in between, and you place the distractor on the lateral sides of each of the bony segments, it moves forward, but the segments will rotate and collapse into the cleft space, causing inaccuracy of the distraction. So for this kind of patients, sometimes I will do the simultaneous grafting if the orthodontist want it. But the purpose is not to stabilize the bone because the bone graft is just not strong enough to counteract this rotation. So for these patients, I would just put on this occlusal plate that wrapped the entire crown of the upper teeth. So using this occlusal plate to keep the relative stability between these 2 or 3 bony segments. Yeah, that's the instruments I use for the cases with no alveolar bone graft before OGS. And I will keep this occlusal plate in place for at least 2 months.
And I think you also answered the next question as well, so we'll skip to the next one. So the next question is from Dr. Thao, and the question is, how do you handle a distraction screw falling out after 3 months? And how do you control collapse of the maxilla?
Okay. Wow. Okay, complications, right? Okay, the falling out of the screws, I personally have not experienced any falling out of the screws because it's completely buried under the mucosa, right? So I do see exposure of the plates and the screws, like through the gingiva, but I have not seen like a complete fallout of the screws. So, but if that occurs, well, if the bone is still in place, I guess I will not do anything to if it fall out really. So the second question is, sorry, I forgot it. The second is
The second question is, how do you control any collapse of the maxilla?
collapse, right? Collapse. Okay.
Yes.
Okay. So it's very difficult to manage it because that's why I do everything I can to prevent it, right? I do everything I can to prevent it, either to graft the bone properly before the OGS or use this occlusal plates, as I mentioned, for at least 2 months to prevent it. I do have cases that the bone segment like collapse into the cleft. So in that case, you have to do OGS again to like put it back to its normal occlused position. And yeah, do discuss with your orthodontist before you take care of these complications. Maybe they can save you by like orthodontic compensation.
And our next question is from Dr. Valmont. And the question is there a decrease in VPI if you increase the post-op period? And the second question is, when do you decide to return to do VPI surgeries?
Okay. So okay, I'll answer the first question. Whether there is a reduce in VPI if I shorten the period between like to remove the distractor earlier? Is that the question?
I think it means if you remove the distractors a little bit later, would it decrease the VPI conditions?
Well, I don't have direct data to answer this question, but theoretically, I don't think that will happen. I don't think that will happen because like if you move the distractor earlier, oh yeah, if you move the director, are you expecting the bone or the attached soft tissue to goes back a little bit to reduce the VPI? Is that the hypothesis of the question? Because I have to like the major goal of this DO treatment is to move the bone forward. I try to like keep it in places and do whatever I can to move it forward and keep it there. So the VPI is the risk I have to accept, right? And I can manage it secondarily. So I will not try to remove the distractor earlier just to so that I can reduce the VPI. So that's not my that's not the way I consider it, the question. And also at what stage I would do this VPI correction after distraction, right? So my speech pathologist suggests to wait for at least 1 year if there is VPI recurrence after distraction. So most of the VPI after distraction occurs early, right? Like immediately after we finish the distraction, the bone is moved forward and the soft tissue moves along, and there is no time for them to adapt with the new position. So most of the VPI nasal emission occurs at that stage, and gradually some of them will just adapt this new position, and the VPI will disappear by itself. So my speech pathologist, according to their observation, that the VP closure status might experience change within 1 year. So usually I would suggest to do this VPI correction at least 1 year after the osteotomy surgery.
And Dr. Belmont clarified that the question was, is there less VPI after longer post-op period, which you just explained that you would wait 1 year to observe and then to see if the VPI condition improves before you proceed to do any VPI surgery. So thanks for the clarification. And I think that's it for our Q&A session. Thank you so much. We bombarded you with a lot of questions, but thank you for answering.
It's my pleasure. My pleasure. It's just my English is not good enough to completely express my my thoughts. I apologize for
actually, your English is amazing.
Thanks. I watch too much
Amazing.
American TV.
Yeah.
Thank
So,
you. Yeah.
what?
Okay. Thank you, Junior. Thank you, Jingtao, for your very excellent and your comprehensive presentation to focusing on the DO for the patient with the cleft. And you try to differentiate a different scenario to accept different treatment prototype. You have a lot of different weapons, internal DO and intraoral DO, and as well as OGS at the same time, and you do the ABG at the same time, and you do surgery first at the same time. Quite a lot of so complicated issues all happened in your cases. I know now I have a limited time. For example, maybe I will consult you when we have time in person today. Yeah, for example, for some difficult cases, is separated and you perform ABG as well, and how you could synchronize the different DO in each side, and also patient has that bone graft as well, and how you can plan the vector to go the lesser segment and the greater segment, because you have designed or every plan in advance, because you will try to design the force is more than 8 or less than 8, you will change OGS or the DO, right? So it's still very complicated scenarios in all your cases. Yeah. So we are so appreciated you can share and without and unreservedly. Yeah, thank you very much. By the way, would you like to introduce your C-Trans the conference again to our ICC audience? Yeah, in this June and July. Yeah.
Oh yeah, it's the time will be, it's actually a 2-week international forum. It's a very good opportunity to communicate and seek for potential collaboration. So the forum is actually sponsored by our government. So the participants, the hotel expenditure will be covered by our government. So it's 2 weeks, and it will last for 2 weeks, and it starts in June 21st. So if anyone's interested, just contact me.
Yeah, sure. And if you don't mind, you can share the information in the ICC Facebook,
Sure.
our society. Thank you very much. And the other very good event this year Bangkok. Dr. Jia, would you like to share the information of AO phase this year?
Yes, thank you very much, Bang Yun. I would love to warmly invite all of you to join us at a Fed Ahead this year in Thailand. It will be a wonderful opportunity for us to reconnect, exchange ideas, and shape the future of facial surgery together. We truly look forward to welcome you there. It will set up on the 1st to 3rd October this year. Thank you.
Yeah. And welcome all of your participation. Yes. Finally, I would like to invite all of you to take a group photo. Please turn on your screen, and I would like to introduce our next ICC webinar in the coming week, 7 days later. Our next speaker is from the UC San Diego, Professor Benjamin Mansenberg, and his topic is the alternative minimally invasive approach to cranial synostosis. And looking forward to your participation as well. Yes, and I would like to count to 3 and please show your smile with all of us. Today we really learned a lot of impossible to possible from Jingtao. Yeah, and he has a lot of very new advance and very good idea for us to treat those difficult cleft cases. Yeah, Kangen nowadays is not to using the DO anymore because we have very limited resource to applying those hardware. So we still have to learn from very our good friend, new older friend all over the world. Okay, 1, 2, cheers. Thank you very much. So good morning and good evening. Thank you for your coming, and I have to say goodbye to all of you. See you the coming week. Bye-bye. Thank you, Jingtao.
Bye-bye.
Thank you, Professor
Thanks very much.
Fayaz. Thank you,
thank you.
Jia. Thank you, EK.
Thank you.
Yeah. Thank you very much. Okay. Oh. OK。哎，学姐，我们再重新上来好了，我们再重新上来一下。好好。OK，拜拜拜拜。